Hi. Good afternoon, everyone. And welcome to this special grand round that we wanted to discuss a very timely topic, the Zika virus. And first of all, Craig Sable is just going to come up to say a few words about our global health program. And then Roberta Debiasi, the division chief for infectious disease, is going to tell us what we need to know about Zika at our doorstep.
Many of you received an email from Mark and Elizabeth on Friday announcing the initiation of our global health initiative that's going to be focused on research and education, global health activities here at Children's, and we're really excited about this, and we want to invite you all to come to a reception right after this grand round in the mini atrium, and you'll be hearing a lot more about it. Thank you.
Okay, so thank you all for coming. I ran into Kurt Newman in the elevator, and he said, do you keep making up these viruses so that we think you're valuable? But I'm not, I swear, I'm not the one doing this. It's just been quite a year for viruses, so I think we could call this part 5 of emerging viruses. But this one is really heated up in the media. I'm sure you all are aware of what's been going on. I'm going to try to bring you up to speed, really up to, a few minutes ago, because the slides change pretty rapidly. So our objectives are to understand the scope of this current Zika virus outbreak. I want you to recognize the clinical presentation of Zika infection, whether that be in a regular adult, child, or an infant born to infected woman. We'll talk a bit about evaluation and testing of potentially infected individuals, and then talk about, at the end, prevention, what's going on with research with vaccines, and what you need to know about traveling. So I'm going to start with a case presentation because I'm lucky to be part of the Fetal Medicine Institute headed up by Audrey, and we actually have been handling cases already. And this is just to get your mindset that this is really not something, far off, far away that you're not going to see. You are going to see it. We are seeing it. So this is a 33-year-old G1P0 DC resident who, like many of us, likes to go to the Caribbean, went to Belize, Guatemala, and Cancun at 11 weeks gestation. 2 days after she returned to the U.S., she developed low-grade fever, erythematous rash. It started on her chest and spread over her body. She had myalgias and some mild photophobia, which she actually didn't notice, but when I asked her about it, she said when she looked at the laptop that she noticed that. In retrospect, she had no joint symptoms, and she was really, mildly ill for about 5 days. Interestingly, her husband, who was with her, had the identical symptoms at the same exact time upon return. She was seen appropriately. She's an educated person and thought about this, saw her OB, and had a fetal ultrasound pretty much while she was still symptomatic with the rash, and it was normal. She had testing set up through CDC, both PCR and antibody testing, which we'll talk about later, that were positive and confirmed that she was infected. And then she had a repeat ultrasound 4 weeks later, which was normal. And unfortunately, at 20 weeks, she had an abnormal ultrasound. And that's really where she interfaced with our Fetal Medicine Institute. And I think we're really lucky to have that here, where we can all come together and look at these complex cases together, particularly in an emerging area like this where there's really little published yet. So we'll come back to that case, and Audrey's going to show us some of the imaging, but I want to walk us now through some of the more general stuff so you have an idea of the scope of the current outbreak, if the computer will advance. I know they've had a little bit of issues with this computer today. Well, it's going to be a long lecture if we can't get past slide 1, but there we go. So, and also this computer kind of didn't like one of the pictures, but basically this is just showing you that this is a single-stranded RNA virus. It's a flavivirus, so if you know anything about dengue, yellow fever, and West Nile, it's in the exact same family. Non-human and human primates are the reservoirs, and mosquitoes are the vectors. And this was just a very simple diagram showing the human and a nice mosquito down here, and it used to have these arrows going back and forth, and just making the point that during outbreaks, if you have an infected human or primate, that's how it's maintained and expands throughout the population. The clinical features are really pretty mild for the average adult if you're not pregnant, and I think this is a very important take-home point and one I've made to people who call me that are concerned. So 80% of people are completely asymptomatic. 20% are symptomatic 2 to 7 days after being bitten, and they really have a pretty mild illness, pretty much as described in that first case that I just described. The symptoms last 5 to 7 days. Very rarely do people need hospitalization, and the case fatality rate is low. But really why this has gotten the attention it has is this major risk for the developing fetus, particularly this association with microcephaly and some other birth defects, and now increasing reports of Guillain-Barré, which again is both of these are in association at this point. And we're going to cover those later, but I want you to learn a little bit about how this has emerged in the Americas first. So this virus was first identified in Africa in the Zika forest in Uganda, and it was actually the dengue team that was out there doing mosquito studies, and they had a cage with a macaque animal, and the animal became ill, and they did analysis really more geared toward their dengue studies, and this is when this virus was first isolated and identified as something unique from the other flaviviruses. It really hasn't gotten much press until about 2007. There was a small epidemic in Micronesia on Yap Island, and in 2013 there was a larger epidemic in French Polynesia, which interestingly did have 8 times the normal reported cases of GBS in that small area. So this sort of is when around 2008 through 2013, it started getting more attention. And in fact, in South America now, as you know, in the last year, there has been, actually the year before, kind of around the time that the FIFA World Cup was happening, people that were working in clinical situations started seeing fevers and rash illness that looked a lot like what we in ID think of as dengue or chikungunya, but it seemed milder, and their testing didn't really pan out for dengue or chikungunya, and it was called, you know, the mysterious illness. And more people started noticing this, but it really wasn't until a year later when people started noticing this surge in the incidence of microcephaly in this particular area in northeast Brazil that people started lining it up and saying, hey, you know, maybe these things go together. So now, as you know, there's 4,000 cases of microcephaly that have been reported as of February, and we're going to talk in more detail about that in a moment, and now it's spreading throughout the Caribbean and Central America. So this is just a little graphic to show you. This is where it started. 2007, it moved over to Micronesia, then it came over to French Polynesia, it kind of skipped over here to the Cook Islands, then made it to Easter Island, which was really the first, you know, emergence in the Western Hemisphere. And now we have this situation that emerged in 2015, went the wrong way. And then in the last, you know, several months, as you've been hearing, it's really marched its way up all the way through Central America. So these slides are updated, you know, every 2 days. There were some gaps, but essentially now you can see this is all affected. So these are now areas that pregnant women should avoid, and we'll talk more about that later as well. So how concerned should we be in the United States? You know, to date, we really have not had local transmission, meaning an infected human spreading it via mosquito to another human being. We have had 33 confirmed cases in the U.S., and these have all been U.S. travelers who have visited countries where Zika is known to be found. The U.S. mainland does have the Aedes mosquitoes, which are the main vector, and there are 2 of those, which I'm going to show you in a moment. And it is possible, therefore, that we could have, similar to how things marched up through Central America, it could march up through the United States. But we really don't think that's going to happen on a large scale for a couple of reasons. So these are the 2 vectors. This is the primary vector, which is Aedes aegypti. It's been around for a long time. And in the U.S., it's really, its distribution is really in these lower states, particularly the Gulf Coast of Florida. And in fact, this is the same vector that spreads dengue and chikungunya, and we have seen cases of dengue and chikungunya in these states. But what we're hopeful for is that we haven't seen an explosion of cases and a lot of local transmission in those states. So we're hoping, since it's the same vector, same family, that would sort of be what we would hope to see with Zika virus. The thing that's a little concerning to some of us is this other species, Aedes albopictus, really has a much wider distribution in the U.S., even up into New York and Connecticut, and this can transmit the virus. So right now, since this is evolving, we don't know how important that's going to be, but that is going to play a role in how worried we should be. And this was actually cut out of a New York Times article that was very nice from just this weekend. It just kind of makes the point that our travel routes, you know, from the epicenter to all over the U.S., there are many, many flights each and every day going back and forth all over the United States. So there's certainly the opportunity with cases moving back and forth, and there's certainly the opportunity with the appropriate vectors. So on February 1st, the World Health Organization, Margaret Chan, announced Zika as a global emergency because of this explosive spread in the Americas. We have heard about Brazil, but Colombia is actually the second most affected cases, including a lot of pregnant women. They're most concerned about this now moving into Africa and Asia, where the vectors are present and where there are the world's largest birth rates. So this is a really big risk for those babies to be. And so this is a launch of a global response to fight Zika, both to set up surveillance in these low and middle income countries to really detect signal where they don't have the infrastructure where that signal would be picked up as easily as in a more developed country. And then there will be 20 to 30 sites established worldwide to really get involved and make sure that we're not missing an outbreak after, too much time goes by. And, of course, mosquito control, education, and warning people about travel will be part of that. So objective 2 now you understand that global epidemiology is to recognize the clinical presentation, and we're going to talk about several clinical presentations. In infectious diseases, the two main things this looks almost identical to are dengue and chikungunya. And I'm not going to spend a lot of time talking about them other than to say they are fever rash illnesses that can also have arthralgia, bone pain, and they tend to be much more severe as compared to the average person with Zika. But those of us that are seeing the cases now, really, if you're thinking of those two, you should be thinking of Zika. There's really no reason you'd say, well, I'm going to check for one and not the other. A lot of respiratory viruses can cause fever and rash, and other bacteria and parasites can as well. So this is a nice picture of what the rash looks like. It's a diffuse maculopapular rash. Some people say it's slightly itchy. It's really not, anything about it that's really distinctive compared to other maculopapular rashes. This is an example of the conjunctivitis. So this is bulbar conjunctivitis without discharge, and this is a crazy computer, but just ignore that. But you do get a good picture of the eye there. It's not a purulent, so there's no discharge. It's just injected. And then this is an example of swelling of the joint, or there can also just be overlying edema without frank joint involvement. So that's sort of the classic presentation, your average 5 to 7 day mild illness. I think the two things that have people's attention, though, are this association with Guillain-Barré and then the association with the congenital malformations. So let's talk about Guillain-Barré first. Most of you know this is an acute inflammatory polyradicular neuropathy, and it results in weakness. You lose your reflexes. You can be paralyzed. It's a very rare disorder where the person's own immune system damages the nerve cells and leads to these findings. And it may last a few weeks, but it can be prolonged. Most people fully recover, but some are permanently paralyzed, and some do die from respiratory failure. So we don't yet know for sure that it causes GBS, but it's pretty clear that there is an association that's pretty well documented now. So if we look back at 2013 in that French Polynesian outbreak, there clearly was GBS reported that was out of proportion to what they usually saw on that small island, or those small islands. And then if we look now, we have reports coming out of 5 nations, so Brazil, Colombia, El Salvador, and Suriname. So in Brazil, there's 76 cases, of which 42 are confirmed as Guillain-Barré. 2/3 of these had a Zika-like symptom history. And if you look overall at their baseline rates compared to now, that's about a 20% increase over what we saw before. Colombia has 86 cases just by the end of the first year, and that's, compared to 250 a year as their usual. El Salvador has 46. Their baseline is 170 a year. Suriname, 13 cases with a baseline of 4. So clearly, people are more vigilant and reporting it, but I think there really is an association that's needs further evaluation, and that's really what we know about it right now. So I think what we know more about is the microcephaly association, and I put in some pictures here because you may have seen many of these in the media, but I think a picture really states the case. So these babies are being born with extreme microcephaly, which most people are defining as less than 3rd percentile, or at least 2 to 3 standard deviations below what should be there. And this is just an example of a normal head versus a microcephalic head. If we look at this association in Brazil, the Brazil Ministry of Health reported this marked increase in the number of babies, and we now are up to over 4,000 cases between October 2015 and January 2016 as compared to this baseline of 150. So clearly, big increase. Now, when we look at what we know so far, and this changes every day, but as of today, only 400 of these 4,000 have been confirmed as microcephaly. Now, that's still more than 150 a year, but there's still a lot of work to be done. Of these 404, 17 are lab confirmed, 2 were miscarriages, 15 were live births, 12 of 15 have survived. But in 700 of these 4,000, they actually have, it turns out they were not microcephaly. So I think what we're going to find is that it's not going to be 4,000, but it's definitely going to be an increased incidence from what was seen before. And there's still much work being done. And this is just a graphic showing you where the epicenter of those cases are. So these big red areas are possible cases that are under investigation of microcephaly in this northeast corner of Brazil. And the dark gray are the ones that have been confirmed so far. So these are just some more graphics. Very, very small head. This is a child, and this area that's affected is, of course, not an affluent area, and so some of these pictures are pretty heartbreaking. This is another microcephalic child getting a bath. So this is not for you to read all this, but this is a nice summary from the first 35 patients that were enrolled in the Brazilian Society of Medical Genetics embryopathy registry, looking at features of these microcephalic kids. And what you'll see, or I'll tell you if you can't see, is that most of them are in the first trimester, so 57% were first trimester, 14% second trimester. And then if we drop down here to other things, calcifications were seen in 74%, ventricular enlargement in 44%, neuronal migration disorders like Pachygyria or lissencephaly in 33%. And this is just the tip, of course, now that there's more active study going on with these increased number of cases. So at this point, I wanted to stop and bring you back now to the case that I told you we evaluated here, one of the cases we evaluated here. And this child, at the point of that abnormal ultrasound, they reached out to the Fetal Medicine Institute, and Andre's going to come and show us some of the imaging from that evaluation. You can use this to point, and to advance, you have to use this.
So when I got the phone call from the referring doc in the community, I was really glad that we had the sort of fetal program that we have here that doesn't just focus on surgical conditions, but is broad-based, multidisciplinary, and essentially is prenatal pediatrics, as we like to think of it. And Roberta's team has been an amazing recent addition to our team. And then we have, I think, some of the world's best neuroradiologists on board that do our fetal neuroradiology, and our fetal radiologist, Dorothy Bullis' team, and Judita Loomis, who helped us with this case. So we were able to mobilize this team. And what we see here is the ultrasound. Now, antenatal ultrasound is the first sort of level of fetal imaging. And what you see here is, which one is the
top.
What you see here is, this is the fetus's head here. And this measurement here is a standard measurement of the cranial size. So it measures the size of the bony structure around the brain. And people have come to use this as an indicator of brain size. And that can be misleading in some situations. The other standard measure that is made is the biparietal diameter between the two parietal aspects of the skull. And what you see here is the ventricles over here. This is the posterior aspect of the downside ventricle, and it actually falls within what we consider a normal size, less than 10 millimeters. But as you move forward, you can see this anterior horn of the lateral ventricle, and it is clearly enlarged, and you get this draping down of the choroid plexus. And on this side, where the resolution is not as good for technical reasons, there is a suggestion that there's a heterogeneous choroid plexus on that side, possibly with possibly due to bleeding into the choroid plexus. So,
advances. You have to use
is this one here?
No, you have to use this. That doesn't work, unfortunately.
So this doesn't project too well, but what you can see here, so a lot of what we've heard about in the press is microcephaly, and although most of these kids end up microcephalic, I think an important thing to remember is that when we first see these fetuses, they might not yet have reached that point. And what you see here, I'm sorry about being so poorly projecting, but this is the head circumference, and it's still within the normal range. So if someone was out there just looking for microcephaly, and this lady, in fact, was reassured about her ultrasound, this might go under the radar. But you do get some other information here, and that is that between the previous visit outside and our visit, there was a significant drop-off of head growth, even though the absolute number was still in the normal range. And here you even get the sense that the biparietal diameter actually decreased over time. Now these are, as far as I know, these are the first reported fetal MRI studies anywhere in the world. And the whole neuroradiology team came together to point out different aspects of this. So what we have at the top is our case, and what we have here is a normal control that John Mernick pulled for me over the weekend. And so these here are two axial views, so sliced through like this with the two lateral ventricles here. And you can see, comparing this normal 20-week fetus, you can see, first of all, the thickness of what we call the cerebral mantle, and you can see how thin it is over here. You can also see, and this is a very interesting observation by the team, and that is this dark layer around the ventricle. That's the germinal matrix layer. That's where all of the neurons proliferate that will eventually go out to the cortex. So this is where all of the division occurs, and then they stop dividing and move out onto the surface. And you'll also notice that there's this trilaminar pattern, the cortex and the subplate, what's called the subplate zone, that's critical for the cortex, and then this germinal matrix layer over here. And if you compare that with our case, you can see some areas where there's this trilaminar pattern, but it's very difficult to make out, especially up front, in the frontal regions, this germinal matrix, suggesting that the virus got into the proliferative area and either killed the cells or prevented them from multiplying for other reasons. And here you see the same on the coronal view, which is a view taken in this direction. So the other, just to get back to the timing of this case, this lady's symptoms were at 11 weeks gestation. The principal, most proliferative period for this layer here is around 3 months. So the timing is unfortunately very good in this lady for a knockout of those regions. Another observation that we made was this structure here is the corpus callosum. This is a normal control. The corpus callosum is the highway that goes between the two cerebral hemispheres, and it starts to develop in the front aspects here, and then expands and gradually grows back to overlie these structures here. And as I said, it starts somewhere around 11 to 12 weeks gestation, and here you can see this very undergrown corpus callosum here, again suggesting that the process of development was interrupted. So it looks to us as though there are probably two processes going on, that there's a destructive process which resulted in hemorrhage, and that there were other images of the hemorrhages that are more convincing, but I didn't show them. So there's a hemorrhagic process, but then there's also at the same time a dysgenetic process, probably what we call a disruption of development. So the normal developmental program was started off normal and then became disrupted. So those are the features of our case.
Thank you very much. We're very lucky to be able to see those. There's also been a report of some other ultrasound findings in the radiographic literature. So this is just 2 cases that were recently published. And this shows some cerebellar calcifications, again, dysgenesis of the corpus callosum, some atrophy and caudate calcification. And this is another case where they had severe unilateral ventriculomegaly, other calcifications in the ventricle, absent thalmi, thin brainstem, and pons. So I think there's going to be more coming out as we have great imaging, and we're on the cutting edge of this, so stay tuned for other things that we'll find out. So the last objective, or the last main objective, is to be familiar with the suggested evaluation and testing of potentially infected individuals. And so right now, we're really using 2 ways. One is RT-PCR, which is indicated in patients whose symptoms are within a week of presentation. And then we use serology if they are presenting 4 or more days after they become symptomatic. So, for instance, our patient, she showed up really within day 3, so she had both. On day 5, so she had both the IgM testing as well as the PCR testing. What's a little tricky about the serology is that if you just do the serologic testing, this is all done by CDC, it's not commercially available yet, it will cross-react with other flaviviruses, so then it requires another very labor-intensive step called plaque reduction neutralization assays, where you then use specific antibodies to distinguish between whether what you're seeing is a true positive for Zika versus dengue or chikungunya. And you can imagine that if there's only the CDC doing it, it's not even up and running at all the state health departments, there's quite a backlog, and therefore the initial recommendations for who to test was quite limited, but this will be expected to expand as we ramp up the ability to do the testing. So these next couple of slides, I don't want you to focus on all the tiny print. I just want you to be aware that there are 2 very important guidelines that were released really around, I think, January 25th, that focus specifically on what you do if you're managing a pregnant woman and what you're doing if you're managing an infant. And essentially, originally they really asked us to do ultrasound on the pregnant woman first and only do testing if there were abnormalities. There was sort of an uproar about that because of the very points we talked about. The ultrasound is not very sensitive, particularly early on, and it really was cumbersome. So they actually came out with a revised guideline just 3 days ago. So you can imagine how quickly these guidelines are revised. But essentially now they're saying if you're a pregnant woman with a history of travel to an area with transmission, go ahead and test, period. And even if they're asymptomatic, you can go ahead and test. They'll accept specimens within 2 to 12 weeks after they return. It's worth doing testing, and they'll help you decide, or we can help you decide if it should be PCR or serology. If they are positive, then they are recommended to have the serial ultrasounds and to consider amniocentesis by PCR for Zika testing, which is what happened in our patient. If they are negative, they still have ultrasounds and are followed serially if those are negative. If they find abnormalities, even if the mom was negative, you would retest the mom later. This then is the other document. Again, don't worry about all the fine print, but the bottom line is there are guidelines for the infant now who actually has microcephaly or intracranial calcification, and you basically are, they will accept specimens to perform Zika testing, which I'm going to show you in the next box. And if they are positive, then there's a whole set of things that we want to do for that baby, which include evaluation of hearing, evaluation of the eyes, careful neurodevelopmental assessments, because there really are going to be downstream effects of the infection, or the concern there will be. So the actual testing we would do on the infant, or in the case of a miscarriage or fetal loss, same things apply. We would do RNA on the infant as well as immunoglobulin M with those neutralizing antibody tests. If there's spinal fluid available, we could send that for Zika RNA PCR. If you can get placenta or umbilical cord, we can do immunohistochemical staining for the virus and also do PCR on those tissues, on frozen tissues. And if not already performed during the pregnancy, you would then go ahead and do the mom if you're just picking up a baby who mom had not previously been tested. This is more of the guidelines in that document, but essentially this talks about make sure you look at the head, the eyes, the ears, and do a very careful neurodevelopmental evaluation. And then they also bring up the point that, you know, not all microcephaly and calcification, don't forget, is Zika, right? We're all very focused on that. But these children still need to have a genetics consult or a dysmorphology consult. They may need consultation with a neurologist, such as we have at the Fetal Medicine Institute, to do better imaging. You might need us to look for other congenital infections, which are very common, of course, CMV and toxo, and other teratogenic effects that might have caused the child to have these abnormalities. So the long-term effects, of course, are really why we're all here talking about this today. We're really worried about this large group of children that may be at risk. And they may have seizures, developmental delay both in speech and motor milestones. They may have problems with movement and balance, feeding problems, difficulty swallowing, hearing loss, vision problems. And this was actually shared to me by one of our ophthalmology, the chief of ophthalmology. In their boards within their profession, they have been seeing in up to 50% of cases macular abnormalities in these kids. So that is why it's one of the recommended parts of the evaluation. So this is just some common questions I've been getting, so I just thought I'd put them out there. If a woman has traveled to an area with Zika virus transmission, should she wait to get pregnant? You know, right now we don't know the risk to an infant if a woman is infected with Zika, but clearly it's a concern. It usually remains in the blood of an infected person for a few days up to a week, and when I talked to my CDC colleagues, they said as far as they know, they have never isolated more than 11 days from a bite. Now, of course, when there are other modes of transmission, we can talk about maybe that's longer, but for a classic, you know, if you went to Caribbean, got an illness, probably 11 days is the length. And there is no dormant, latent state. It doesn't reactivate from what we know. The virus will not cause infections in an infant that's conceived after the virus is cleared, so after the viremia is gone. It should not cause problems, and it shouldn't cause any problem with future pregnancies. So, you know, a woman contemplating pregnancy who has recently traveled to an area should definitely consult her healthcare provider. And I'm sure you've been hearing all the controversial advice about, you know, Brazilian women being told to not conceive for 2 years, basically, is one of the recommendations that's being made. They're hoping that as this spreads, more and more people will become immune, and therefore this will kind of die off and have less of a risk for women. So the last thing, which I didn't include the initial objective, but over the last 2 weeks, you know, people have brought up all these questions. So I just want to quickly talk about a couple of these because you've, I'm sure, been seeing them in the media. You know, from all of these potential transmission modes, which you've been hearing about, the vast majority really are from the bite of the vector. So most of the control measures are based on avoiding travel to the mosquito areas, and if you're there, using appropriate measures. There is potential in utero transmission, as we've just talked about. There may be perinatal transmission via viremic mothers. I'm going to talk a little bit about sexual transmission because that's been the biggest news for the last week. Transfusion-related has come up, and Naomi Lubin very astutely asked me the first day I saw her, you know, what about transfusion? And it turns out in that Polynesian outbreak, when they did sort of screening of about 1,500 donors, they found about 3% were positive. So this is going to be a problem, and, you know, that's a whole other lecture talking about how we're going to get screening of the blood supply in. The Red Cross, I think, now is recommending people delay 28 days for donating if you've been to a region. And then you saw just last week this kind of really scary report that they could isolate viable virus in saliva and urine, and what does that mean? You know, right now we don't think, even though it's there, that it transmits, so you might think about it like HIV. We can find it in a lot of places, but that does not mean it's going to transmit in using those. But let's just look at sexual transmission because that really has gotten a lot of press. So on February 2nd of this year, just a few days ago, the first known case of Zika virus transmission sexually occurred within the U.S. in Dallas. This was infection by sexual contact with a partner who traveled to Venezuela, and there was good epidemiologic evidence that it was not via direct mosquito bite. There are other instances where this has been documented, so this is not the first time ever, but it's the first time during this particular outbreak. So in 2008, There was a scientist studying malaria in Africa who returned to the U.S. and infected his wife before developing symptoms, which is a pretty scary thought. Both ended up with a classic illness, and, you know, in retrospect, they were able to confirm that this was Zika. In 2013, during that Polynesian outbreak, they could find live virus in the semen of a 44-year-old. And in these two cases, the men actually had genital pain and blood in their semen, even though they did not have symptomatic illness initially. So that at least gives you a little bit of hope that, you know, there might be some clue that you might be excreting in your semen. But really, right now, we really don't know, and CDC will not come out and say, you know, you're fine. So that has led to these interim guidelines for prevention of sexual transmission of Zika virus, and basically it says the duration of shedding is unknown. I can tell you, even when I call my close contacts in Fort Collins, they say we really don't know, and we're really doing a study. So they're doing a study right now, and I'm sure another guideline will come out in a few months. Men exposed to Zika who have had a pregnant partner should use condom or abstain from sex until the baby's born. And interestingly, there haven't been any cases of female-to-male sexual transmission yet, but again, this may evolve. So, you know, finally, what can we do about treatment? There really is no specific treatment. You should avoid, just as in dengue, aspirin or NSAIDs because of the risks of hemorrhage, but antipyretics can be used. There's a lot of people working on vaccine, both Brazil-U.S. partnerships, private companies such as Sanofi who already have a lot of expertise in other flavivirus vaccines, so they're basically going to try to link in the genome of the relevant Zika into the platform they already have for some of these other flaviviruses. Other countries are working on these. This company is actually looking at treatments, not vaccine. So, you know, there's a lot going on, but really most experts think it's going to be many, many months or years before we actually have a good vaccine. So it's not going to help us right now. And so that is why the CDC issued this travel alert on January 15th saying that anyone who's pregnant in any trimester really going to any of these areas should not go. And if you do go, you need to be tested when you come back. And I think we've talked about all this. We've had 33 cases documented in the U.S., but of course, many, many cases are being submitted. This is a question I get asked a lot. Well, you know, we're going to fill in the blank beautiful place in the Caribbean. Should I go, and should I bring my kids, and what about my child who has an immunocompromising condition? And really, there's no statements made yet, either yes or no. So you have to take the risks and benefits of vacation with what we know about this or don't know about it into consideration when you make that decision. So this is really concerning to us. You know, now here we go. It may have started all at the World Cup, but now we're about to head into a lot of people getting together. And as they said in a quote from someone at Carnival this week, there's a lot of saliva, there's a lot of sex, there's a lot of mosquitoes, there's a lot of perhaps blood exchange. So, you know, this is really a kind of a scary proposition, but, you know, people are thinking about it. They're actually actively spraying mosquitoes on a regular basis in the stadiums, like getting ready already now. So they're taking this seriously. This is an interesting paper, if you want to look at it, that's looked at modeling of, you know, what could happen when you get that many countries and that many people together, which we don't have a lot of time to talk about. But, you know, there's a lot of people coming from a lot of countries that will all be converging. And a lot of these people come back to the Americas, Europe, and Asia. So stay tuned on that. Prevention, really with this World Health Global response, it's now become really a much more financial, a lot of money put towards, you know, figuring out what to do about this. So 220,000 military personnel are actually going around in Brazil in their uniforms trying to eradicate the mosquito. It's actually, people have to let you, like if they come to your door, you have to let them in and look for places to, you know, try to eradicate the areas where these things like to breed. But I think you've heard on the news, they can breed in a teaspoon of water. So this is really a difficult proposition, to be quite honest. But they're doing the best they can. The CDC is coming out with all sorts of infographics to remind people, even here in the U.S., that, you know, we have mosquitoes that transmit Zika, chikungunya, and dengue, but that bite in the daytime, but we also have the ones at night that transmit West Nile. So I'm not saying don't go outside, but you have to be aware, you got to be aware that you have to use mosquito protection, and probably the most common question we get asked are which ones work and which ones are safe. So this is a really nice infographic from CDC. One point is that if you're using sunscreen, you should put the repellent on top of the sunscreen so that the repellent is, you know, not masked. You should put it on every couple of hours. You can use permethrin-treated clothing and gear if you want. They have lots of clothes now that you can just buy that have the permethrin in it. But if you're going to use repellents, you really need to use Environmental Protection Agency registered agents. So those are DEET, picardin, oil of lemon, eucalyptus, and this IR 3535, which I think I'm sticking with DEET personally. But and we cannot make any statement about the efficacy about you know, some of these other citronella oil, cedar oil, geranium oil, peppermint oil, soybean oil. So they smell great, but we don't really know that they work to repel mosquitoes. And these are just some other points that CDC is really ramping up their efforts to educate people. So, you know, if you are sick, you do want to try to avoid going out and getting exposed to more mosquitoes because you could be then starting a local transmission. So they're trying to keep you to stay home, you know, at least for a week while you're likely to be viremic. If you're going to the tropics, think of these things. You know, remember, they bite day and night. Use your repellent. So they're trying to really get the word out for people. And, you know, I'm going to end on this. You know, as much as we know and as much as coming out each day, there are 100 million other questions that are just not answered yet. So I'm just leave you with some of these questions that I get asked every day. You know, what is the risk to an infant? We don't know. How long should you wait, you know, until you get pregnant again? We don't know. What is the mechanism? So as Audrey mentioned, you know, there's probably multiple mechanisms, both through that developmental arrest cycle if it's early in the pregnancy, but also this, you know, toxic effect even later in the pregnancy to some structures, which we'll learn more about as we go. What are the upper limits of duration? You know, so far we're saying 2 weeks seems pretty good. How long can virus be spread in sperm? You know, as we saw with Ebola, we had people popping up with Ebola in their sperm 6 months later. So, you know, we don't know the answer to that yet. Can asymptomatic individuals spread? Are saliva and tears infectious or not? We think no to that answer, but we don't know for sure yet. Are there other mosquito vectors? I only told you about 2, but there are, you know, if you're an entomologist, there are hundreds of species of mosquitoes, and that's an area of active research, which ones can actually transmit. And then finally, are there specific groups that are higher risk? Specifically, you know, are young kids or immunocompromised at higher risk? We really don't know. So I'm going to end there, and I think we should have a little time for questions, which I'm happy to try to answer, but may not be able to. So, yeah.
Over the question, there are cases where in body fluids the virus persists even after the blood has been cleared. The question I have is, it's been known to be positive in breastfeeding, breast milk, and I just wanted to ask you, we have now a mother with a history of Zika. What would be your recommendations in a resource-rich setup like ours?
The current recommendations are to continue to breastfeed. So I think they're still looking at whether or not it can be found in breast milk. I think there has been at least one case where they could find it, but the recommendation right now is that there should not be interruption of breastfeeding.
What is the natural immunity to the virus? Can same individual get it every 2 weeks?
No, that's a great question, which I should have put. And actually, that was the question one our patient asked us, is like, well, am I immune now? You know, am I safe? You know, and it is thought that once you are infected and have proven infection, that it confers permanent immunity. So you should not be able to get infected with Zika again if you've had it once, which is different than, for instance, dengue, where there's 4 different serotypes and you can be infected 4 different times. So once, we think, confers immunity.
There was an article in the Post today from a Brazilian scientist who suggested that this is a disease of poverty. It's where it's in the rural areas, not in the cities so much. Do you know anything about that?
Well, I mean, that's where we're seeing most of the cases, in that epicenter in Brazil. But I do know that it's probably not, and that has to do with the mosquito vector as well, because some like cities more than, and some don't like cities. But I know, for instance, in Africa, even though it broke out in 1947 and kind of went away for a while, when it did reemerge in Africa, it actually wasn't an urban center. Now, granted, an urban center in Africa may still not be what we think of as an urban center here, but I think we really don't know the answer to that.
Just out of curiosity, the individuals who were infected in third trimester, was there a difference in the significance of microcephaly between those in the first trimester?
Well, so from the slide of that first 35 cases, if you took all the 35 cases, the minority of them were infected in later trimesters, but it wasn't zero. So, but I don't have a further analysis for you, but what I would say is that if you got infected later in gestation, of course, you're not at risk for the interruption of the developmental sequence, but what we are appreciating is there probably are some direct toxic effects of the virus, even if you have a developed brain. And what we don't know is, you know, at what point are you not at risk for that? So I don't think we really know the answer to that. We do have cases that we actually are working on with colleagues across the street who have later infection pregnancy, and we'll be evaluating that as well. Okay. Oh. Here you go.
A question, Roberta, for you and for Audrey. What are our opportunities for collaboration in the research that will help define the pathophysiology of the brain illness? We have strong partners in Brazil, in Colombia, folks that we have clinical relationships with. I know the advanced imaging and the technology is sort of based here, but is there a way that we can work with our partners, scholarly partners in South America to shed some light on the pathophysiology of the brain injury?
A great question, which I don't have the answer for it. I don't have personal connections, but you may.
And it is a good question. I think it's one that we should explore.
When you could imagine 10 fetal MRIs at a critical serial showing the evolution of the disease with the kind of imaging that you and Catherine Lamperopoulos do could define the pathophysiology.
Right.
Okay, are there any short or long-term adverse outcomes for a developing fetus that occur when a baby does not have microcephaly? For example, are these possible developmental delays even though the head size is within the normal range? And is there a head size other than that meets the definition of microcephaly where the infant still is at risk for long-term problems?
That's an excellent question, and it should go on the last slide. We really do not know. But I think it's a big concern. People are concerned. It's certainly not black or white. You have microcephaly, you know, you're affected, and you don't have microcephaly, and you're fine. And, you know, the fact of the matter is, as we all know, when we have an infant, only time tells you if there's developmental delay. So until we have proven positive kids that are followed prospectively, we're just not going to know the answer to that. But I would be concerned. Yes. Yes.
Have there been any cases where the mother has been asymptomatic, but yet, in other words, no rash, but still a carrier?
Yeah, so not so much a carrier, but could she have had asymptomatic illness but was viremic and passed to the infant? Yes. But I don't think we know how often that happens because they're just, you know, starting to collect. But it's plausible. It could happen. If you're asking, did it happen? I don't know. But it could happen. If you were viremic but asymptomatic, you could pass. And that's why the recommendation was in that algorithm, if you come back, if you're pregnant and you go to one of those countries and you come back, whether you're symptomatic or not, you should be tested. And that if you're asymptomatic, well, how would you know when to go? They recommend going 2 to 12 weeks after your return and be tested.
We have 2 more WebEx questions. The first one is, do other fetal organs besides the brain show Zika pathology?
Not that I'm aware of, but I'm sure that hasn't been looked at. Oh, well, that's true. I did tell you about the eye, so the macular problems with the eye, I would consider that part of the brain. But, you know, as far as heart or liver or kidney, I'm not aware of any reports of that.
And if newborns or young children contract the Zika virus, do they have any risk for long-term problems such as neurodevelopmental delay?
We don't know the answer to that, but right now there's no, that has not been raised as a concern. Granted, the attention has been focused on the most severe tip of the iceberg, maybe, cases, but for now, we don't know the answer to that.
Roberta, quick question. The breastfeeding recommendations, I can see that going to area of resource limited where there is no alternative safe option. Seeing the inflammatory changes we've seen now, seeing the presence of inflammation, and though you did answer a recent question, there is no evidence, does it worth to take the risk of exposing to breastfeeding when we have alternative safe option in this country? Again, I fully render this for the resource limited settings.
Yeah, you know, I can only echo what the CDC recommends, and that's what they recommend at this point, that the risks are far less than the benefits, so they recommend continuing to breastfeed.
Have the past outbreaks with Zika virus had microcephaly, or has there just been none of volume in the past to show it?
Great question. Yeah, so it's because those other two outbreaks were, you know, one was on a tiny little island and one was a little bit bigger, but what they've done now that they've found this outbreak is they've gone back and retrospectively tried to see, and there is an increased incidence. It's about a 4 to 10-fold increase over their baseline in those French Polynesian islands. You're saying because it's been a year, have they looked at outcomes? Not that I'm aware of, but that would be a great idea.
Excuse me. If you have any suspicions in the serologic test in the course of diagnosis of Zika virus infection, what's the next step to confirm diagnosis? Because you said that the results of serologic tests may be overlap with other flavivirus such as the yellow.
Mm-hmm. Well, it would be in a pregnant woman you're talking about, right? Yeah, so there are actually strict criteria for if it's a positive serology or not. It's either negative, meaning there's no IgM reactivity, or it's inconclusive, meaning there's reactivity, but they can't prove that the reactivity is 4-fold higher than against dengue or chikungunya, meaning it could be nonspecific. So that's called inconclusive. Or it's positive, meaning it's 4-fold higher reaction, specific reaction compared to dengue and chikungunya. So your question was, if it's negative, if it's positive, what do you do?
Diagnosis of this virus is checking for PCR virus genome?
No, because the PCR positivity is really a very short, limited time. You know, you're only viremic for that 11 days. So currently you don't check PCR on the person if they're definitely beyond 2 weeks. So, but if you do the IgM testing, you can say it's either negative, possible, or definite by using the serologic testing, and that persists for quite a while.
Okay, we have another WebEx question, 2 WebEx questions. If a pregnant mom is tested at 2 weeks post-travel and negative, does repeat testing need to happen closer to 12 weeks? And is IgG testing for Zika available?
Yeah, they're not very clear right now in the guidelines for how often you should repeat the testing, but they are clear that you should have repeated ultrasound. So even if you're negative initially, you should have repeated ultrasounds if you had a symptomatic disease.
If a parent brings their child in to be evaluated and they assume that there is a chance that they could have been infected with Zika, are we able to test after that the child is 6 months, a year old?
So like a child coming in with?
That's microcephaly.
With microcephaly, yeah. So that is actually the guideline for the evaluation of the infant. So you would do the eye exam, the hearing exam, everything else you would do to evaluate a microcephalic child, and then you could call CDC. You couldn't do PCR because it would be too late, but they could look at serologic responses, which it might be too late, but I'm sure they'd be willing to do it. Yeah.
Excuse me, another question about the diagnosis. Can we say that serologic test and PCR are using a serial scenario for diagnosis of Zika virus or not? These two tests are alternative. We can use from serologic test or we can use from the PCR for diagnosis of Zika virus infection.
It really depends on when you're presenting. So if you're coming in within, like I said, 7 days of illness, like you have your rash, then they're going to do PCR. If you're 4 days, at least 4 days in, they'll do PCR and serology. And if you're past 2 weeks, they're only going to do serology. So it really depends. And you don't have to worry about remembering it because they're going to tell you which one they're willing to do for you when you give them the information. Yeah.
All right, you skipped the question. Is IgG testing for Zika available?
Not commercially, definitely not, and CDC is not doing it routinely. Now, I don't know if I'm sure they're using it for, seroprevalence assays, because this is supposed to confer permanent immunity. So, but when you're actively investigating a patient, it's the IgM that's more important.
In the ambulatory setting, we see a lot of kids that are coming back from South America. What should we do when we see these kids?
I mean, if they're normal children, I don't think you need to do anything. I mean, if they come back, though, in the ER, and we've been getting lots of calls, and our fellows are getting pretty good now at fielding these. If they're coming back from an affected area and they have a fever, rash, illness, then just like we check for dengue and chikungunya,
if they don't have a rash and they have just upper respiratory infections, would we test those kids?
No.
Okay.
Okay. Well, thank you all.